So thank you for those people that are joining us, whether it's this evening or this afternoon. It's guess depending on which time zone you're in. Just to give you a bit of background, I'm Dr. Rob Seeley. I'm a GP by trade. I was a GP for 30 years. I'm situated on Vancouver Island in Victoria. But the last 20 years, I've been involved with medical cannabis. And this is kind of a topic this afternoon that is near and dear to my heart because of living on Vancouver Island. There are a lot of seniors that come here to retire and live with their grandparents. It's an elderly population, so a lot of seniors are here using medical cannabis. So I've tended to gravitate as that's part of my practice, but I have a full-time practice in medical cannabis. And again, quite a large amount of those patients happen to be seniors with multiple comorbidities, et cetera. So I came up with the topic green is the new gray, because really cannabis is something that is being shared by more and more seniors. It's the fastest growing demographic. So I'm kind of the grandfather of medical cannabis with 20 years of experience, as I mentioned. So most of my colleagues think of me as a senior as well. So I come across it naturally. So let's get started. I will see if we can get this working. There we go. We will ready to rock and roll. Here we go. So why is cannabis so popular among the elderly? Well, elderly are often looking for a different opportunity to use a medication that perhaps they've tried so many other medications before and have had variable response to sort of standard therapies, standard pharmaceuticals. And if they've been ineffective or associated with intolerable side effects, again, they're looking for an opportunity to try something maybe a little bit different. And of course, as we get older, we get more conditions, whether it be pain or insomnia or anxiety or depression. They all tend to kind of come together especially if a person is in chronic pain. Chronic pain is extremely common, and it brings with it a burden of all those other sorts of conditions, like I say, inability to sleep, etc. Eventually, upwards to 80% of individuals with chronic pain will develop some sort of mental health challenges such as anxiety or depression. It really takes a toll on individuals. And so, like I say, as we get older, we tend to have all these challenges to deal with. And what's interesting about medical cannabis, and by the way, that's a joint. If you haven't seen one, it looks like a golf tee, but that's a joint of marijuana or cannabis, is that cannabis has the opportunity to deal with a number of symptoms at once. It has this multimodal effect. And I'm going to keep coming back to that because when we're treating seniors, we're not necessarily focusing on just one aspect. There's a number of different conditions and symptoms that can be treated at the same time. So seniors are often more open to that because, again, they've had challenges of the standard pharmaceuticals, and they might have had experience growing up in the 60s. They might have been at Woodstock, or maybe if they recall being at Woodstock, they've had some sort of experience with cannabis in the past. The thing about cannabis is it's been around for a long time. It's been around for thousands of years, but what some people may not realize that in the early 1900s, it actually was sort of a standard ingredient in a number of pharmaceutical medications. The large pharmaceutical companies used it as an ingredient in 28% of their medications. Now, the problem is they didn't know how it worked. They knew that it did some sort of positive effect. This is actually an example of the 1880s. There was a cough syrup that had cannabis as an ingredient, but it was only a single one of the ingredients that had alcohol and chloroform and morphine and a few other skillfully combined ingredients. So they knew that cannabis did something in a positive way, and it's stopped these people from coughing and probably all other bodily functions. But it was an effective ingredient, but they didn't really understand why up until the endocannabinoid system came about. Now, sorry if I'm going to go down a science route, but if you understand even the bare bone basics of the endocannabinoid system, you'll understand how cannabis can potentially work and how it can work in so many different regions, because we have this protective system called the endocannabinoid system, which was only founded in the 1990s after I graduated from medical school. They still don't even talk about this system in medical school. Now it's that new, but it's a very, very interesting system that keeps us protected 24/7. So it is a series of these compounds called endocannabinoids, and a series of receptors that are basically everywhere in our body that you can think of, from the brain to the nerves to the heart to the lungs. And what it's designed for is to protect us against some sort of insult to our body. So our body's very smart. It understands if there's a signal that's not good for us, it creates these compounds that are sent out to these receptors to stop the transmission of that signal because it realizes that it needs to protect us. Now, this is what it looks like down on a nerve cell level. And again, I apologize if this looks like it's just, too nerdy, but if you can understand this system, it really helps to assess the potential benefits of cannabis. What happens, it's kind of like dominoes. If there's some sort of a transmission of a signal that's good for us, the dominoes can fall and we're happy. But what happens if there's pain or inflammation or anxiety or something like that, that those dominoes want to fall, but our body is pretty smart. It realizes, no, that's not good for us. It can send back these compounds. You'll see those two in the middle, anandamide and 2-AG, that try and fit into those receptors and keep that domino upright. Basically, stop the signal. It acts like a circuit breaker. So that's important to protect us 24 hours a day. Now, why does this system have anything to do with cannabis conversation? Is because there's other chemicals from the plant or the synthesized cannabis that can fit into those receptors and keep the dominoes upright.
Where are you going?
Stop that signaling. So some of the other compounds that fit there are not only our internal cannabinoids, the endogenous
Just a
cannabinoids.
second, I'll get up.
That on the right-hand side, the synthetic cannabinoids, you can actually get a prescription for one called nabilone or sesamet. But I'm going to talk to you about the phytocannabinoids or the plant-derived cannabinoids. So this is actually a picture of my basement. You can see what I've been doing during the pandemic. It's been a very fruitful year. But it's the female cannabis plants that we're most interested in. And if you look at under a microscope, there's these juicy things called trichomes. And within the trichomes are the various cannabinoids. Again, we make internal cannabinoids. The plant makes a whole number of plant-based cannabinoids, upwards to over 130 different ones. They also make terpenes and flavonoids. So it's a very complex plant. But it's the cannabinoids that we're going to talk about the most. And the two cannabinoids that you're going to hear over and over again are THC and CBD. Now, they are very different components, but they act very well together. They're opposite, but they're very much complementary. When we think about THC, most people think of recreational, right? So THC can cause the impairment and the euphoria, but THC from a medical standpoint can be helpful for things like pain and sleep and nausea and vomiting. Also can give people appetite if that's what they require. That's what people use it and get the munchies when they're using it recreationally.
That's how she comes.
CBD is very different. It doesn't cause that high or that impairment or euphoria at all. CBD is very, very safe in that regard. It can be useful also as a painkiller, although it's not as strong as THC. But it's probably a better anti-inflammatory, and it's good for our mood. So people will use it often as a pain modulator, and that people can tolerate pain better because it often regulates mood, so it can be useful for anxiety and depression and PTSD. And then it's got interesting properties as anticonvulsant, so for epilepsy. What's really fascinating, though, is we're finding out is a lot of people will say, well, then CBD is the right answer for me. And they'll try CBD and they'll say, well, it didn't work. And what we're finding out more and more is the reason it doesn't work is because the doses that people require for CBD to be activated are usually very, very large, and most people don't get to that point. What really helps is to add a little bit of THC to CBD to activate it. And the whole art is adding just enough THC to activate the CBD without allowing the effects of THC. So it's getting the help without the high by compounding the two together. So when you look at what's the evidence for cannabis, as far as strict double-blinded placebo-controlled randomized clinical trials, there's about 4 conditions that have met that level of criteria. There are things like chronic pain, nausea and vomiting during chemotherapy, people with spasticity and multiple sclerosis, and then seizures,
Oh,
back the very difficult to treat childhood seizures. There's enough evidence that
movie.
cannabis can be useful, especially CBD in those conditions. Well, there is less evidence for things like anxiety and PTSD and sleep, but it doesn't mean that people don't have good responses to it. In real world evidence and real clinical practice, a lot of individuals do use cannabis with great
Nice.
success for these conditions. It just means that there isn't
Oh,
the studies done on them. But just because there isn't studies, the lack of evidence doesn't mean lack of efficacy. It just doesn't. It just means we haven't got the studies to back that up. But again, you'll know a lot of individuals that use cannabis for a variety of conditions because of how it interacts with the endocannabinoid system. Now, what happens when people use cannabis as far as with pain? What exactly happens? What kind of reaction do they have? Well, a couple things. When you go to the doctor, they'll often say to you, okay, tell me on a scale of 1 to 10, how bad is your pain? 10 being the worst pain. Well, when people take cannabis, most surveys will suggest that people's pain score goes down by about 3 points, which is pretty good. It goes from a 7 to a 4, for instance. But what's even more interesting is how it changes the quality of the pain. And how it does that is there's an area of the brain called the amygdala. The amygdala is that center part with all those green receptors, and that's kind of our pain and pleasure center. When cannabis interacts in that region, it often will alter people's perception of pain so that they're able to disassociate from it. Time and time again, people will say, you know what, Rob, if I think about my pain, it's still there, but I'm not thinking about it 24 hours a day. It's like I'm able to walk away from it. It's like I know it's down, the end of the hallway, but I can walk away and it doesn't consume me. And that pain modulation is one of the biggest factors that I see in my own practice is a real benefit in chronic pain. What's also interesting to note is where there's very few endocannabinoid receptors, and that's in the brainstem, the lower part of the brainstem. Why is that important? Because that's the area where opiates go and sleeping pills go. And those are the danger areas where if people take too much of those medications, and that's the opioid crisis, the fentanyl crisis, people stop breathing. So it's a large, risk of mortality. We don't have that situation with cannabis, and so it's extremely different. When you take an overdose of cannabis, people, don't feel well. They'll, feel anxious and paranoid, and they just have to wait it out. It's a very different situation taking cannabis versus a lot of these other medications. When we figured this out, that those receptors are in a parallel universe, we didn't have to worry anymore about using cannabis with opiates. Back in the early days, we used to say, okay, we have to get you off your opiate before we could introduce cannabis. Now we're using cannabis with opiates in an effort to not only increase the efficacy of the opiate, but then allow a reduction in the dose of the opiate. So it's become a really interesting novel harm reduction substance or substitution effect in a way to get people down off of their other medications. And this is extremely important, especially in seniors, as you'll see. When we look at some of the data, the meta-analysis, we're seeing a reduction in things like codeine and other opiates like morphine, fairly dramatic reduction. Again, most of these were preclinical studies. This is a study from a few years ago, but we're getting some very recent data out, not only from just patient surveys, but in pain programs where they're introducing cannabis to, again, people that are established in opiates and seeing a reduction in these potentially harmful medications, which is really interesting. Now, let's segue into seniors and why is cannabis a potentially a good option? Again, it's a good option if there's been ineffectiveness to standard pharmaceuticals or intolerable side effects, but there's also a benefit in the possibility of reducing what we call the pill burden, the polypharmacy. Well, what is polypharmacy? Well, depending on definition, for most people will say taking more than 5 pills at one time. And what happens when we take cannabis, because it works in those different areas of the endocannabinoid system, it may help not only with a person's pain, but it might help with their sleep and might help with their anxiety at the same time. And that would allow us to reduce some of those other medications. And when I say here, stop the pill cascade, You'll know this, familiar scenario. If a person's in chronic pain, quite often they're started on one painkiller. If that doesn't work, they're added a second painkiller. Next thing they're getting stomach upset, so they're on an antacid, and they're not sleeping, so they're given a sleeping pill. Now they're getting depressed, so they're given an antidepressant and maybe a muscle relaxant. Next thing you know, they're into polypharmacy. So cannabis might allow the reduction of that pill burden and reduce the potential drug interactions and side effects. Well, how important is this in seniors? Well, again, if you look at the bare bones definition of polypharmacy, it's more than 5 prescriptions of medications per year. Well, in the community, seniors average 7. In long-term care facilities, 10 prescriptions a year is not uncommon. In fact, 2/3 of all seniors fit the criteria for polypharmacy, taking more than 5 prescription classes per year. There's even 25%, 1 out of 4 seniors take more than 10 prescriptions, and 8%, about 1 in 12, I guess, take more than 15 prescriptions. And you can only imagine with that much pill burden, how do you even know which side effect is responsible to what medication? What's the correlation? What's the drug interactions? And as we can predict, if we get more conditions as we get older, we're going to most likely be prescribed more medications at the same time. So that if we reach the age of 85, 13% of those individuals will have more than 15 prescriptions per year. So it really adds up. Why is this important? Because the more medication you take, it correlates with the more hospitalizations. 1% of seniors will eventually be hospitalized with an adverse drug reaction. And we know that it's really hard to get hospitalized these days, let alone be seen in the emergency, but it has to be a pretty severe drug reaction to end up in the hospital. But there's an increased risk, a direct correlation with the number of medications that an individual is on. With more than 10 prescription leads to 60% of adverse drug reaction hospitalizations and the increased admission rates as each prescription goes up. Within that class of medications, can we come back to the opioid crisis? It's the opioids are responsible for the 8th most common prescription in seniors, and it's actually the 3rd most common if you're residing in a long-term care facility, with twice as much use of opioids in long-term care facilities than if you're living out in the community. And it's the 3rd most common adverse drug reaction that will lead to hospitalization. So opioids in seniors is a problem, as it is across all age groups, but it's certainly quite a concern in seniors. Now, when we segue back to cannabis and you say, okay, well, what do people use cannabis for? And this was a survey that was done on almost 600 patients a few years back, looking to say, see what condition would you be treating yourself for if you're using medical cannabis. Now, these individuals could only pick one condition. So the number one condition by far is chronic pain. And we see that survey after survey after survey. But in amongst chronic pain, as I mentioned, you're going to see other symptoms such as anxiety and insomnia, etc. And you'll see those conditions in the top 10. So by far, chronic pain is the number one reason individuals use cannabis for medical purposes. When individuals do introduce cannabis into their system and they're on previous pharmaceuticals, that same survey looked to see what happened to those, previous medications. And we saw across all the major drug classes, month by month, a decrease in the use of things like opioids, other analgesics, antidepressants, anti-seizure medications, which are often used off-label for chronic pain, benzodiazepines, which are sleeping pills, and muscle relaxants and other sleep aids. So month by month, as people were on cannabis, we saw a reduction in these pharmaceuticals. With that, we were looking at, well, if a person's using less opioids, how significant was the reduction in opioids? Well, it turned out it was very significant. On average, about a 74% reduction in the opioid amount over a 6-month period. So it wasn't just like they skipped 1 or 2 pills. There was a drastic reduction in the use of opioids. And we know it's very difficult often to get off of opioids. They're very strong, but it showed us that synergism, that additive effect of using cannabis alongside opioids can be very, very effective. Another knock about cannabis, though, is it's costly and it's not covered under medical plans. Not many medical plans or extended providers will cover it, and only under exceptional circumstances. Well, interestingly enough, this correlates. Not only is this potentially a better efficacy and a better quality of life, but there is a reduction in the financial burden. Because if you can reduce your pharmaceutical amount, not only is it a safer choice, but it's better for your pocketbook. So there was an average reduction of about 87% in the cost of medications. Now, I did some of my own calculations, and that's about the same price as what an average person will use in cannabis. So it's almost a break-even point. So cannabis isn't necessarily more expensive, but it can replace the costs of when you reduce a person's previous pharmaceuticals. So who's gotten behind this is the Arthritis Society of Canada. This is a brochure that's been out for the last few years now, and it was given out to a number of their members to take to their doctor and say, can you please have a conversation with me about medical cannabis? Can you get me authorized? Can we get going on this? Well, a lot of physicians are still hesitant. They don't feel like they're comfortable authorizing or managing patients with cannabis. That's where we have the cannabis clinics thankfully, that we can turn to and get that sort of advice and support. Because again, there's not a lot of education for physicians out there. So this is where it's a full circle moment that we need that supportive team. So the Arthritis Society is also behind research, and they're looking at their members. This is at UBC in Vancouver. They looked at 264 individuals with arthritis, and they said, okay, what does it do for your pain, the cannabis do for your pain, and what does it do for your function and your mood? And what was interesting, and this really surprised me, is that cannabis reduced the pain even more effectively than anti-inflammatories like your ibuprofens and your naproxens and that, but also reduced the pain even better than opiates. Beyond that, though, is going to what I mentioned about how it changes pain perception and disassociation about pain. People were less depressed about their pain, and their pain was less irritating. So better quality of life and function with individuals with arthritis. And again, most of these were seniors. Now, what about cannabis and the brain? This is a question I get asked all the time. What is it going to do to our cognitive function? Because we saw all the commercials, growing up about, this is your brain on pot and you're going to lose your memory, et cetera, et cetera. Well, it looks like it's quite the opposite. More and more studies are showing that there's an actual rationale, behind the use of cannabinoids in brain function. A lot of my practice has to do with individuals in long-term care facilities with dementia, with behavioral and psychological symptoms of dementia. And typically, a lot of these patients are treated off-label with antipsychotics. There's a risk, there's not much reward, but it's sort of become the standard of care in long-term care facilities. More and more, we're seeing a switch, certainly in my own practice, where we're treating individuals with cannabis, a combination of THC and CBD, getting them off their antipsychotics, and we're seeing a better efficacy, less sedation, less side effects of these antipsychotics. Beyond that, there's some really interesting research at this point, mostly in mice, about what it does to the brain tissue. We know that in Alzheimer's dementia, individuals will develop these protein plaques. They're called amyloid plaques, and they'll get these neurofibrillary tangles they could look at under a microscope, under autopsy. I mean, not a very good way to diagnose while a person's alive. But they do these brain tissues and they can see these protein changes. We see the same thing when cannabis is introduced, again, in dementia-prone mice, genetically programmed mice to develop dementia. They're seeing a change in these tangles. They're basically eliminating them. And beyond that, they're seeing mice doing the maze test so that their memories are improving. We haven't got to the point where we're got full protocol in humans, but it's looking very promising, so promising that the US Department of Health has actually patented the potential. And it looks like cannabis so far is even better than what's presently on the market, which has been quite disappointing from the pharmaceutical standpoint for behavioral and psychological symptoms and memory changes in dementia. So the future's looking bright in this direction. So there is a rationale because the endocannabinoid system is so vitally important in our brain normal development and when it goes haywire in the development of dementia. So the future is looking bright for things like traumatic brain injuries, concussions, post-stroke, because we know cannabis has been shown to protect our brain at times of trauma and disease. So again, not there with protocols, not big abundant trials at this point, but because of that vitally important endocannabinoid system, I think the future looks extremely bright in this area. Now, I like to always say, let's address the elephant in the Zoom. It's not just that easy to write a prescription and hand it over, and get it filled at Shoppers Drug Mart, your prescription for cannabis. Cannabis has a lot of moving parts. And again, I will say this is where having a support team is extremely important. Somebody like a cannabis educator in the cannabis clinics or a physician that's got a lot of experience with this, because there's challenges as far as picking the right combination of THC and CBD, picking the right dose, how to administer it. What about all your other prescriptions that you're on? What about drug interactions and side effects, etc. So let's look at administration. As it makes sense, most often individuals, especially seniors, will use the oral method, basically an oil or a capsule, swallowing it, which has a bit of a delay in action, usually about 60 to 90 minutes before it starts working, but then a long duration of anywhere from 8 to 12 hours. When you inhale it, which again, not many seniors will do, but it's a rapid onset. So sometimes we use inhalation for, breakthrough symptoms of pain because it gets in the system within 3 to 5 minutes and only lasts 3 hours, kind of like a roller coaster. But for the vast majority of patients, it's going to be oral, long duration. And so usually a dose in the morning and a dose before bedtime. Sometimes what we'll do if people are challenged with insomnia at nighttime is we'll add a little bit more THC to the oil because again, the benefits of THC helps to sedate people a little bit more. So sometimes we'll do mostly CBD in the day and maybe a bit more THC with the CBD at nighttime. The adverse effects, these are THC related. CBD, unless a person's taking a lot of CBD, which most individuals don't, the reactions as far as side effects are going to be THC related. And those symptoms that we have to watch for in seniors are the ones in red. Obviously, we can't, afford dizziness and drowsiness, people falling down if they have osteoporosis and breaking a hip, etc. So we want to be careful of the use of THC. THC has a role. Don't get me wrong. I think we need to have THC as part of the equation, but we don't want to overdo the THC. And cognitive effects, again, if you're just doing THC alone, then those risks in red might be showing up. But if we're just using a small amount of THC in amongst the CBD, I don't think you're going to see these types of side effects. Now, the only side effect you may see is if individuals start feeling really good and they sneak out of the long-term care facility late at night and join their pals. What about drug interactions? This is always a big deal that people will get stuff off the internet or they'll go to the pharmacy and they'll get this reams of paper about be careful when you're taking cannabis, CBD interacts with this, that, and the other thing. Those are all potential interactions. When I mean that when I say that in real life, at the doses that we use, there's only a few medications that I kind of keep my eyes, wider open to. And that's to blood thinners, especially warfarin, clobazam, which is an anti-epileptic, and some of the chemotherapy agents. Beyond that, unless a person's using very large doses of cannabis, it's only a potential interaction. So most of the concerns that have been out there and written down and on the internet are based on very, very large doses that in reality we don't use. And some of them are based on mouse models and extrapolating the data. So in clinically, there is no medication that is a complete contraindication, but you should be aware of blood thinners, clobazam, and chemotherapeutic agents. Now, with all of these challenges, we can see that cannabis is still becoming incredibly popular. In fact, the demographic that we're talking about today is the fastest growing demographic. Individuals over the age of 65 are using cannabis faster than other age groups for medical purposes. Other age groups are using it for recreational purposes. But with all of these challenges of getting a support team and how much to use and all the rest of it, 73% of individuals across all age groups don't go through the whole trouble of getting the coaching and the supervision. They will often, purchase it either at the recreational store, but a full 50% will get it from a legal black market source. So who knows what's in it as far as THC, CBD content, or the quality, the consistency, if it's grown properly, if there's any fungal components, etc., molds. So it's important to do it. I definitely would suggest under the supervision of cannabis educators, physicians, getting properly authorized, getting the medical supply, that's regulated, so and you can rely on the content of THC and CBD. But especially important in seniors, where again, you want to know that there's not an excessive amount of THC. Oh, that looks like the end. So I'm going to stop there, and hopefully there'll be some questions that I'd be love to tackle. It doesn't matter if it's a question in seniors or any other topic that you may have. Feel free to unmute and shout them out, okay? So if you have if you have a question, I think it's most effective if you can find your unmute button, which you scroll at either the top or the bottom of your screen, and then we can tackle them as we go, okay?
And for those of you who don't want to actually talk into the microphone, you can also use the chat feature at the bottom.
Okay, I have to find my chat box there.
Hey, Dr. Seeley, it's Jim. I have a question for you.
Sure, thank you.
So I currently take CBD as an anti-inflammatory, and something I noticed that comes with my medication is it's a titration guide, I think provided by Health Canada through my supplier, and it mentions that 40 milligrams of CBD a day is a maximum dose. Can you comment on that? Because I don't find that an effective dose.
That's a great question. So what's interesting is I think of 40 milligrams. So I've been on consensus guidelines for the treatment of pain, and there was a global task force. And this was one of the things that we struggled with there was 20 physicians from around the world. And we sat down for 2 weekends and tried to come up with what would we give for a guideline for the use of CBD. So here's the thing with CBD, as I kind of alluded to, CBD is useful for pain and inflammation and modulating how we perceive pain. But more and more we're finding out that if you took pure CBD, it looks like the starting dose per day is around 650 to 750 milligrams per day. So most individuals don't take that amount. What they do instead, because that would be a large volume of oil and a large amount of money to do that, it'd be like drinking 2 bottles of it a day. What makes more sense is to introduce that THC to the equation. So where we came up with the consensus guidelines, we said you could take, they've studied it in up to 3,000 milligrams per day in children with epilepsy. So CBD has a wide range of therapeutic value and a wide range of safety, but the rate limiting factor is usually the volume of oil, which can upset the stomach, or the volume of cost. So we actually said that 40 milligrams, at that point, you can go beyond it. There's no reason why you couldn't go beyond it. But at that point, that might prompt you to say, it might be more valuable to add a little bit more THC. So we came up with that 40 milligram as kind of that's a goal that, maybe you should start reevaluating and look at how you could make that CBD more effective. So think of CBD as your go-to, as your building block, but how much THC do you have to add to it to activate it without feeling the THC within it? And at 40 milligrams, that's kind of where we thought about cost and all the rest of it. So there is no hard, fast rule. Like I say, you could take 2000 milligrams of CBD. When you're getting to that point, though, that's when the potential drug interactions happen as well. But again, nobody could afford 2000 milligrams of CBD. So 40 milligrams is not a hard, fast rule. It's just starting to be, let's maybe anticipate adding a bit more THC. But in my own practice, I have people that take 250 milligrams of CBD per day, depending on their situation. But are they taking THC with it as well? Absolutely. So, but there's not a magic number that 40 milligrams is the maximum by any means.
And your tolerance will get higher over time. I mean, I take 600 a day, but my tolerance has grown in 10 years of, being on CBD oils. So
yeah, but where I get around that is usually adding more THC to it, because the thing is that the yin and the yang about that is usually if you're on, say, 600 milligrams of CBD, it would take a fair amount of THC in there before you'd feel that, because it looks like the co-administration of the two together reduces the THC side effects or the THC impairment. So it seems like the more CBD there is, the less likely you can, it's going to be hidden. The THC is going to be hidden in amongst that CBD.
I see John here has a question in the chat, Doctor.
Okay, I can't see my chat
If
box.
you go down to
Where
the
are
bottom, I think it'll probably just show up there, bottom of your screen.
Oh, there we go. Does THC interact negatively with Xarelto and methotrexate? Okay, so THC with Xarelto, so a blood thinner, methotrexate, often used in rheumatoid arthritis. It's sort of a biologic, somewhat of an anti-inflammatory. No, is the short answer. It's more CBD that we have to be a little bit concerned about with Xarelto being a blood thinner. And again, it's less of an issue than the traditional old-fashioned blood thinner warfarin. Warfarin interacts with everything. Xarelto, when I see my patients, unfortunately, you can't measure the reaction when people are taking cannabis and Xarelto or these novel anticoagulants, these newer anticoagulants. So the only thing I say to my patients is, you know what? It's very unlikely you're going to have a reaction, but watch for easy bruising or gum bleeding or nosebleeds. If that starts happening, then there could be an interaction, but typically there's not, again, at the levels that we give into medical cannabis patients. Methotrexate, same thing. You're not going to see that at the levels. All of these, though, are going to show up as potential when you search the internet or get a printout from your pharmacist. But in clinical relevance, I don't think you're going to see that. Any other questions out there? One of the questions that people ask me is, what about coverage, right? So extended healthcare coverage and that. And more we're seeing a benefit that's potentially there. I think there's now something like 17 different insurers that will consider medical cannabis under certain circumstances. 5 years ago, there was none. So we're seeing even, well, in British Columbia here, the Insurance Corporation of British Columbia for, car insurance, WorkSafe, like the WCB, they're considering it on a case-by-case basis. So we're seeing a change. We're not seeing it on a national drug plan at this level. That might take a while yet. Some individuals will also ask and say, well, why isn't it covered? And quite often it comes down to the fact that it's a plant and it doesn't have a DIN, or a drug identification number. To get around that, some people will get a prescription for Nabalone or Sesamet. So a number of individuals will say, well, why don't I just take that? My doctor can prescribe it. I can go down to Shoppers Drug Mart. It's a pill. It's been around for a long time, and my insurer will pay for it because it's a drug identification number. The only issue with that, though, is it's a synthetic THC-like substance. So everything that we've talked about the differences between THC and CBD and how they interact with the endocannabinoid system, and that you have to be careful with THC as far as the side effect profile. When individuals are written a prescription for Sesamet or Nabalone, they're only getting THC. And that's a really big difference. You're not getting any benefit of the CBD, but insurance companies will sometimes pay for the Sesamet because it's synthesized from a pharmaceutical company. What I've had some individuals do, if they get coverage for that, is then they pay for the CBD on their own. So at least they're getting some coverage for the THC-like substance, and then able to afford the CBD on its own and combine the two together. The other thing that comes up all the time too is traveling, right? So you can't carry cannabis products, plant-based cannabis products outside of the country. International borders is still a no-no. Obviously, it's okay right across Canada. And that's another issue where sometimes people will get the prescription for the Sesamet or the THC analog. But for most patients, if they're traveling, for instance, to the United States, which nobody's doing these days, you can, once you arrive in your destination, quite often you can find the similar product at that location.
Yeah, the United States hasn't quite caught up to us yet. They're getting
Not
there.
quite, not quite. Yeah, they're thinking about it, but we're pretty progressive here doing what we did. A lot of people will also say to me, "Oh, Rob, now that it's, cannabis has been legalized for a couple of years," and I'll remind them and I'll say, "Well, actually, for medical purposes, it's been legal for 20 years, and that's when I started this practice." But people often get mixed up and think it's only been legal for a couple of years. But it was really kind of kept on the down low for many, many years. But back in those early infancy days, they were not utilizing CBD at all. In fact, when I authorized my first patient in 2001, we had a choice. There was only one supplier. It was a 9% THC. It was just the bud. There was no CBD analyzed. So it was very, very, small selection. And nowadays we've got this wide array of cannabinoids and different ways to administer, et cetera. So we've come a long ways, and it will only get better and better. And I think the future lies in some of these other cannabinoids way beyond THC and CBD, and talking about terpenes and flavonoids and how these things interact in the plant. The science is looking more and more in that direction. So I think the future looks extremely bright in the medical cannabis space.
Dr. Seeley?
Mm-hmm.
Yes, I wasn't aware until you were talking about it that you need to have some THC to have the CBD activated.
Yeah, I
And
think
what
that's sorry. Mm-hmm.
No, I'll just say I'm taking CBD for pain during the day, and then I'm taking the THC at night for sleep. But I'm just noticing on my bottle here, it says CBD 27.47 milligrams per gram. And then it does say THC 1.1 milligram per gram.
There you go. Yeah.
So is that what you're talking about?
That's exactly what I'm talking about. That's an excellent date. So is that your daytime one?
Yes.
Yeah. So that's an excellent daytime one. So you won't, I don't even know if if you took the pure 1 milligram THC, you probably wouldn't feel that. But now wrap it up in the 27 milligrams of CBD, you really won't feel that. So that's where the CBD helps out, but the THC helps the CBD. So it's kind of a nice, again, combination of the two together. And so If you just took that 27 milligrams of CBD, that'd be probably close to placebo, to be quite honest.
Mhm.
So once you add that 1 milligram of THC, now you're activating it. But at nighttime, if sleep is an issue, pain is an issue, that combination might not be sedating enough at all. If a person's laying awake at nighttime because of anxiety, then the 1 to 27 ratio might be okay. But if they're laying awake because of a pure sleep problem or pain, usually you have to add more THC to that mix. So we'll do it just like you're doing, where you'll take a CBD dominant in the day, but
Mhm.
take a little bit more THC at night. Does your nighttime one have any CBD in it as well?
No,
Okay. Okay.
it's just THC. It says 23.31 milligrams per milliliter, I guess.
And how do you sleep with that?
Well, I'm going through a regime where I'm trying to get off of a sleeping pill, so I'm gradually increasing the THC and diminishing the other,
Yeah. Good.
and just going through that process right now.
Yeah, that sounds like a great process, because I mean, if you've been on sleeping pills, it tells me right away, you've had quite a sleeping issue probably.
Yes.
And people get stuck on these sleeping pills for years and years, and try to come off them is really difficult. But if you add that THC at nighttime, you can
Mhm.
substitute and start that seesaw where you reduce the medications, so that substitution effect is really quite strong. And I mean, I'm going to be totally biased when I say this, of course, but I'd much rather see people on the THC or combination THC CBD than traditional sleeping pills.
Well, I'm working on that. And just one final question
Mhm.
on the CBD with a little bit of THC. Now I'm increasing that again over time to try and, address pain issues.
Mhm.
So when they say 27.47 milligrams per gram, like I'm now up to 0.75.
Mhm.
So
Yeah. So what
I
that means is
going
you're
up on
taking
that.
0.75 times the 1 to 27. So you're taking 0.75 milligrams of THC
Yes.
and 0.75 times 27. So what's that?
Whatever.
20 milligrams of CBD about.
Mm,
Um, but that ratio always stays the same. Every time you increase your dose, it's always that 1 to 27 balance.
all
So
right.
the real key, the real art is picking the right oil and then increasing your dose until you hit your sweet spot.
Mhm,
But it's logical to use like a 1 to 27 in the day. I mean,
mm,
that's the one for most people. Some people can tolerate a bit more THC in the day, but
mhm,
for most people, that 1 to 27 and just gradually increasing it, it's always going to be safe, because you're always keeping that same 1 to 27 ratio. And if you slowly increase it,
mhm,
then you'll find your sweet spot quite often. Most people say, well, should I take a large amount right away and get it working right away? Not necessarily.
mhm,
Quite often it takes a while for CBD to kind of reset those receptors. We think it changes the shape of those endocannabinoid receptors. So it takes anywhere from 5 to 7 days to do that. So often, if you just kind of gradually increase your dose, you'll find your sweet spot easier that way. Um, the thing as well we know is that if you get THC side effects, which would be pretty uncommon with that ratio,
mhm.
those THC side effects go down the longer you're on it. So for instance, your THC at nighttime, if you took a large dose right away, of course you'd feel pretty wonky. But
Mhm,
if you gradually increase it, your body becomes accustomed. It tolerates THC side effects. So this is called tachyphylaxis, where you don't lose the effectiveness of the THC, but you reduce the side effects of THC over time. The other really fascinating thing about that is quite often people will find their sweet spot and then stay on it for years. And if anything, their dose will go down a bit. And studies out to 3 years have shown this. I've seen it in my practice time and time again, where people, I'll check in with them and I go, how are you doing? They go, oh, great. What's your dose now? And it's often less than what it was when I talked to them before.
mhm.
So because of the endocannabinoid system changing and it's constantly in flux, it doesn't need as much often, quite often down the road. Very different than other medications like standard, opioids or benzodiazepines for sleep, quite often people's dose keeps going higher and higher and higher because there's a development of tolerance. We don't see that with cannabis. In fact, we can often see the opposite, which is really interesting.
All right. And could I ask one last question?
Sure.
I've been diagnosed through my osteopathic practitioner that I have very tight myofascial tissue, and she's doing work on that.
Mm-hmm.
How does this affect that?
Well, what's interesting about that, so it's kind of akin to fibromyalgia, and you'll hear about fibromyalgia time and time again. And
Which I,
do you?
yes.
Okay, so the thing with fibromyalgia, and this might have been your experience as well, is it usually took a long time to diagnose because there isn't a blood test for it, right? There's no, you can't send an X-ray and find out, oh, this is fibromyalgia. So for years, there was even some thought that, oh, fibromyalgia is in people's heads, right? It doesn't exist. Well, guess what? It does exist, as you know, and it looks like it's related to the endocannabinoid system. So there's a Dr. Ethan Russo, who's a renowned neurologist and one of the top researchers in cannabis in the world. And he's written about this syndrome called clinical endocannabinoid deficiency syndrome. So remember those chemicals that we make, those compounds, anandamide, 2-AG? If people genetically cannot create enough of those in the first place, then they're prone to certain diseases. We've not been able to understand up until recently with his work what causes fibromyalgia, what causes things like irritable bowel syndrome, what causes migraines in some individuals. Why do some people get PTSD and others don't? It looks like it's the fact that people are unable to produce enough of their protectant internal cannabinoids. And that's why individuals with fibromyalgia, by replacing what they're not able to make in the first place, they tend to have a very good response to cannabis therapy because it's almost like supplementing what their body can't make in the first place. It's akin to people with hypothyroidism, where their thyroid stops producing that hormone. Well, what do? We give them the hormone replacement. Cannabis can be a replacement in fibromyalgia, if you think of it that way. They've done some really unique studies to try and determine that Dr. Russo's on the right track. And one of them was they took individuals that were survivors of the World Trade Center. There were 64 of them. Half of them had full-blown PTSD. The other half didn't seem to have any symptoms whatsoever, yet they were all exposed to the same trauma. And they measured their blood pressures and cortisols and thyroids. And it wasn't until they measured their endocannabinoids, which is not easy to do. We can't just go to the lab and get our endocannabinoids measured. But they measured, in this case, 2-AG. And those individuals that had PTSD had a reduction of that 2-AG versus the people that had no symptoms. In Italy, they looked at migraine sufferers, and migraine sufferers have a reduction of anandamide. So we're seeing that there's a link in disorders based on what we can do to protect ourselves. And if we can't protect ourselves, then that using the cannabinoids from the plant to fit like a lock and key in those receptors, that's what we're really, really interested in.
For those of you who are interested, I put the link to Dr. Russo's endocannabinoid deficiency research in the chat window. You can click on it and read it. It's actually a really good study.
Excellent. Excellent. It's fascinating.
All right. Thank you. So you're saying myofascial, fibromyalgia, and even irritable bowel can all be.
Yeah. And whenever I say stuff like that, I always feel like I'm a snake oil salesman, right? Like, how can it work for all of these things? It goes back to why I introduced the endocannabinoid system, because those receptors are there anyways. They're screaming out for help. So they've even done studies and looked at people with arthritis, where if your right knee was completely normal and your left knee had arthritis, and they biopsy the two, they can see that there's more receptors, endocannabinoid receptors, in the arthritic knee than there is in the normal knee. Because our endocannabinoid system, almost like waving a white flag, it upregulates, and it basically, like in a garden, it blooms new receptors. And it kind of, they're waving there saying, help me over here, send me some endocannabinoids. Well, if we can't send enough, that's where the plant-based cannabinoids can fit into those receptors. So that endocannabinoid system, I can't emphasize it enough, is so vitally important. And we're realizing how we can use it to our advantage and how we can unlock those, those lock and key situations.
Thank you very much.
Welcome. How are we doing? Is that everything?
I think we might be all questioned out.
Okay. Well, thank you very, very much for inviting me, and thank you for those that logged on. And now you can go back to Netflix.
Thank you so much.
Thank you,
Dr. Seeley, for your time tonight.
Excellent session.
Thank you very much. Take care, all. Take care. Stay safe. Thank you.
Bye-bye.
Bye-bye.
Bye all.